In this module, we'll be discussing knee x-rays. This will cover AP and lateral views. For the AP knee, we'll have the patient on the table. In this module, we'll be performing the examination utilizing the table bucky with the grid. Your camera tube is 40 inches from the bucky or the grid, and you've got your crosshairs pointed directly down toward the knee joint. We'll discuss that in a minute. It is entirely possible to do this examination tabletop, where you have the patient bend their knee and you put a cassette underneath their knee and you do the examination without ever using the bucky. But for two reasons, I'm going to apply this teaching module toward the table bucky, and that is, number one, we have a lot of folks that have a setup where the equipment is already built into the table. They're not able to use cassettes. Also, we have a heavier population, so whereas we used to do a lot of the knees using a tabletop method, now the heavier population has thick knees, thick lower legs, and so it's more and more necessary to utilize the bucky to clean that grid to clean up these images. So I might recommend that you use the table bucky on a regular basis if you can. Now, with the patient's leg extended completely and with them lying down with their knee closer to the table, you'll want to have their toes pointing straight toward the ceiling and slightly inward. This helps to rotate the knee in proper position for the AP. Now, pay attention to this. You want your camera crosshairs pointed directly down just below the kneecap or at the knee joint. Now, it may not be as much as 1 inch, but you'll want to have your crosshairs below the kneecap. Why? Because the kneecap is not your knee joint. It's not located at the knee joint. It's actually slightly above the knee joint. So if you forget this portion here and you go and perform a knee examination on your patient and you center your crosshairs on the kneecap or the patella, your film will be look more like a distal femur than it will a knee joint. You'll have more of the upper leg than you want and not enough lower leg. So you're going to want to pay attention to this and learn it. If you're having a tough time finding the patella and trying to point your camera just below it, a trick is to have the patient bend their knee and then you feel from the back of their knee where exactly their knee joint is. Have them straighten their leg again and you can correct your centering point. You'll want to have your collimators relatively close side to side to include the whole knee itself side to side. But you're going to want to open them up so that you've got, the furthest portion of your upper leg included. And then, of course, you want some of your lower leg as well, because some of the pathology may bleed into either one of these sections. For this examination, using the table bucky, a good baseline technique is 10 mass at 62 kVp. Now, for our evaluation of the x-ray, this is an AP knee. You can see that you've got the knee joint included in here. This can be a little tricky because there's a lot of patients that have anatomy where their knee joints are compromised. They've got disc problems, and what that looks like is these will be close together or on top of one another. In our elderly population, many times you see that. It's hard to see in the joint. But when done appropriately, you can get some joint space in there. This is the tibial plateau, the top part of the tibia. And then, of course, you have your patella here. You can see it. It's just above the knee joint, as I had mentioned. And you've got your condyles and epicondyles of the femur. These are the big bony parts of your knee. If you reach down and grab your knee, this is what you're grabbing here. So this is a well-centered examination. Let me show you some of the overlapping bones so we can identify the good film. You've got the tibia that kind of sneaks up behind the fibula that sneaks up behind the tibia. And when it's off to the side there, you've got a solid AP. Now let's outline the patella. See how clear that comes out? And you can see the patella kind of bleeds in just a little bit into the joint space. But again, oftentimes it's off to the off to the medial side, or it's a little bit further above the knee joint. You want to make sure that you can see bony patterns, see the trabeculi. We've been discussing this in some of these examinations. You want to see bone patterns, because if there's a small break or a hairline fracture or small nuances, cancer, anything, you have to be able to see the bone patterns to correctly identify if there's something wrong with the patient. Here, clearly, we can't see in the joint space very well. We don't see bony patterns. We can barely make out the patella, and so you're getting the idea. You want to see a uniform pattern across the x-ray. This is an underexposure. It's to the other extreme. You can see the overall anatomy, but you cannot see the bony patterns or any clear nuances within the joint space. So this is your objective here in the center of these two examinations. For the lateral knee, you're going to want to pay close attention to what I have to say here, because this might be one of the trickiest x-rays to achieve. It looks easy, folks. I understand. It does look easy. But the more you shoot, the more you realize you have to protect your technique and be very astute at the principles that I'm going to show you here. Anytime you get a lateral knee that's ordered, which is with every series, you must have your notes ready and prepare yourself that you're going to have to pay attention to every one of these details. First of all, again, we're using the table bucky with the grid. We're 40 inches away. Your camera should lock in place with the bucky so you're ready. You get the patient to lie on their side, their affected side, so that the injured knee is down closest to the table. You're going to want to center your crosshairs at the dimple of the knee. You know, when you grab your knee, you've got the bony parts here, you've got the patella, you've got your calf. Well, there's a dimple in your knee. When you bend your leg 45 degrees, it's easier to feel. And when it's the softer portion that kind of goes inward before you reach into the back of your leg. So once you feel that dimple in the knee, then you'll just aim your crosshairs bifurcating right through that. Your knee and your foot are completely sideways, parallel with the table. Again, the knee is flexed 45 degrees. That helps. But even when you have that, I guess I'm going to let you know that is oftentimes hard to achieve. Why? Because, well, we have a patient population that is a little bit thicker these days, and they might have a lot of meat up in here on the outside of their legs, so it makes it tough for them to roll completely sideways and get that knee where you need it. So you might have to do this. You might have to have the patient roll over where they have their top leg folded over the top part of their affected side. So you've got that top femur out of the way, that leg out in front, but their hips have been rotated, so you're getting them more lateral. Honestly, folks, I do every single one of my knees this way. It's a little bit more problematic, but you get better results this way. So this is an examination of a femur, but the position is what I'm referring to. You want that hip to fold over, get everything out of the way. Some people can do it this way, but it may be a better strategy for you to go ahead and get their hip rotated forward. And that way you follow the principles that we've already identified here, and you may be able to get a very good knee. Now let's see what identifies with a good lateral knee. Oh, here's a good technique is 10 mass at 62 kVp. So for our lateral film, pay attention to the image closer to the center on the right-hand side. This is a near perfect knee. It's because you have the femur rolling down. The femur has two condyles. They're just two bumps on each side of the femur. And these condyles are overlapping one another almost perfectly. They're symmetrical, so it's possible to do that. The patella does not rest on the bone. Rather, you have a joint space in here that the physician wants to evaluate. So to see this free-floating sesamoid kneecap or patella bone is a very good film. Now you've got the proximal portion of the tibia, and you see a portion of the fibula as well. A beautiful image. This is what a perfect knee looks like. Now, as opposed to that, now you can see probably a pretty clear difference on the left-hand side. You see the condyles here. One is projecting furthest away from us, and then we have another one that's more magnified. Actually, this one's closer to the cassette. the more magnified one is rotated further away, so our two condyles are completely out of sync with one another. The patella looks like it's growing right off of the femur. You don't see a joint space in there, and the patella looks fatter than it should be. That's enough said. I mean, we can identify a little bit with the tib fib, but these are our two major indicators that tell us that we have a rotated knee. If you run into this, it just tells you that your knee is rotated incorrectly. Some people use a trick of angling their camera about 5 degrees. I don't know why this necessarily corrects that, but sometimes doing that will help. But most of the time I would advise you to keep your camera perpendicular, make sure your patient is rotated correctly for this exam. So now you know what a bad knee looks like versus a good knee.